Well, I want to thank everybody who came to this Zoom meeting. My name is David Kinecki. I am the Educational Director for the Flight and Critical Care Transport Center at Case Western Reserve University. I've always loved critical care transport. I became a flight nurse in 2008. I flew for the Cleveland Clinic flight team, and I consider myself blessed to be in an area that was pioneering using nurse practitioners in critical care transport. So I transitioned from a flight nurse to a flight nurse practitioner, and I flew for the longest time there, I think a total of 8 years. And I also flew for another local team who did a little more trauma than the Cleveland Clinic at the time, and I always wanted to do trauma. And there again, they flew with nurse practitioners and providers. So I've been lucky enough to do the job that I love and get paid what I consider a really good salary because I was a nurse practitioner. I transitioned. I still fly. I work a combination of the intensive care unit, and then I fly probably a lot less than I used to, probably 1 to 2 shifts a month now for Metro LifeFlight. And much of my focus on life now is I get asked a lot by flight nurses, about this NP role. And unfortunately, there's not that many opportunities for senior flight nurses to stay in the industry and become nurse practitioners. So one of my goals in life now is spreading the word about the nurse practitioner role. And that's the reason for this Zoom meeting. I'm aware of three or four flight programs that use nurse practitioners, one of them being Vanderbilt. That's the reason Keith's here. So today we're going to talk with Keith Evans, and then probably a lot of you guys on this Zoom meeting have gotten the invites, but over the next couple months, we're going to talk with the nurse practitioner from the Cleveland Clinic flight team as well, one from the Metro flight team as well, and then another named Jacob Miller, who flew for a team that they did use nurse practitioners, but they weren't successful in my opinion. So the hope there is to share some maybe other options or things you would maybe avoid. Here's the schedule. Everything will be posted on Facebook. I kind of talked about this, but the reason I put this series of interviews together is, number one, I teach the role of nurse practitioners in critical care transport. There's no published data, there's no literature. So all I can do is give my opinions, which are just really opinions. So the hope is that in sharing the opinions of others, we'll start to get an understanding of what the role is and maybe how to define it better so other programs can implement the role. We'll talk about the value of NPs and CCT, share best practices for NP success in CT, and ultimately my goal is to create more NP jobs in the industry so we flight nurses can advance our careers and become flight NPs or critical care transport NPs. And then there is a kind of biased, I guess, or hidden, not really hidden agenda, but I do want to raise awareness for our program at Case Western Reserve, because we are trying to drive this hope that the industry can start using more nurse practitioners in CCT. And with that, I do want to announce that we wrote about this. I have the final review of the publication before it comes out. Watch out for a publication that's going to discuss the role of NPs in critical care transport. And this will also be open access. So although Air Medical Journal is the publisher, anybody with an internet access can read it. With that, I'm going to turn it over to Keith Evans. Keith and I have talked several times. I feel we're on the same page. And some of my students and I put together a list of questions that are kind of common questions that we're going to ask him during this interview. There'll be open questions in the chat that I'll watch that we'll get to at the end. But I think we'll start by Keith, you telling us about your program, about yourself, and then we'll go from there.
All right, perfect. David, I want to thank you for organizing this and getting it going. We've talked over the last few years, especially since we started our program, and how we can advance our practice across the board. So especially within the industry, because the industry is pretty much dominated by flight nurses and flight critical care paramedics. And then how can we help advance? And so one of the things that we have done at Vanderbilt was we recognized that we had a large swath of individuals that were advanced practice. They were flying as flight nurses, been flying as flight nurses for years, but had their advanced practice and had side jobs, essentially working as NPs, whether it be in some of our regional ER emergency departments, local emergency departments, at urgent care clinics. And as the discussion came, we're utilizing their skill set within the air medical transport program. Why not recognize them for what they bring to the table? Knowledge is one of those things that is not necessarily tangible. You can't put your finger on it. You can't say, well, I'm flying as a flight nurse, and all the knowledge that I gained when I was going through my advanced practice and all the skills and knowledge that I learned, I can't just turn it off and say, no, I need to fly as just a flight nurse. So those are the intangibles that come along with this. And so how do we do this? And so what we basically presented to our leadership was, why don't we credential them under emergency medicine, and we'll move forward and we'll increase their scope and things that not just the skill set, but increase their scope while they're flying. So that's how we kind of got here. So I'll talk a little bit about me and my background is I was a prior flight nurse in the Army and Air Force. So I'm one of those weird people that as soon as I finished my service in the Army, went into the Air Force and then back into the Army. So we'll not discuss that too much because that really throws people for a loop. But I had a lot of experience, and my experience came from being downrange in Iraq, Afghanistan, in Africa, and then doing critical care transport. So I was part of a CCAT team. I was also, which is a critical care air transport team in the Air Force. And then I was also a flight nurse within the Air Force and in the Army as a nurse practitioner. So a lot of the experiences that I'd gotten from there. And when I left active duty, I came to Vanderbilt. So I've had 2 jobs in my adult life, and that's been the military and Vanderbilt. So I'm a unique that I haven't flown with other programs. However, I have a lot of colleagues that have come from other programs. I know a lot of individuals with other programs. And so that is the great thing about air medical is it's really small. No matter how vast the United States is, it's really a small industry, and everybody gets to know everybody, and you talk with people and you figure out best practices through each other. So but going back to this, so I graduated as a nurse practitioner back in 2008. I started flying as a flight nurse in 2006. And when I graduated, I was in acute care. And basically, I was still flying as a flight nurse, but I utilized the skills and the knowledge that I had learned to better take care of my patients. Transitioned into a chief flight nurse role, and then I went back and did a postmaster's as a FNP and an ENP because I was faculty at the School of Nursing at Vanderbilt and was doing a lot with the ENP program. So I figured if I'm going to teach it, I might as well go back through the program. So went back, did a postmaster's as everyone else, and then transitioned into one of the program managers for our program, and then that's when we really started looking at this. And so this was about 2017 when we started really looking at this, trying to decide, is this will this profile fit with what we are trying to accomplish as a flight program? So as we progressed, we had more higher level discussions. We had our executive medical directors, our medical directors on board, our administrators, our Office of Advanced Practice, and we figured, yes, this will be advantageous to us and to the quality of care that we can provide to our patients. So we proceeded on, and so we started the clinical process of getting everybody credentialed. And so for those that don't know, credentialing, it's not a fast moving beast. It takes a minute. So by June of 2020, we had everyone credentialed, and that was the first group. So how we went about this was we kind of set some guidelines and said, okay, who here is an advanced practice? We tried to figure out what the best skill set was. And so we have some that are acute care, and then we have some that are family with the ENP. And we tried to decide, where are we going to go with this? And, there's some regulations around what you're able to treat. So acute care, a lot of it is driven by your boards, but some of it is also driven by your state. So in the state of Tennessee, as an acute care nurse practitioner, you can see basically age 16 and up, so what they would consider an adult. So if you were acute care within our program, you could essentially fly as a nurse practitioner, treating the patients that are age 16 and above. And if you are 15 or less, then you would revert back to being a flight registered nurse, and you would utilize the protocols that are in line with how we manage our pediatric population. And so therefore, there would never be I'm stepping outside of my scope of practice. So with the FNP ENPs, they are able to essentially manage from a practitioner level the pediatric patient as well as the adult patient. So when we were creating this, we had to put some guidelines in place that followed the regulations within the state as well as your scope of practice. So as we've put all those foundations in place moving forward, so now we've got our core group, the ones that have been flying as flight nurses, credentialed in 2020. We put other guardrails in place and said, all right, what about new nurse practitioners? Or what about when we have an open position, do we hire directly into the nurse practitioner role? And so as we discussed that, our goal was to make sure that everyone was operating safely. And we want people to be good crew members first and safe crew members. So we don't want, you could have been a practicing nurse practitioner for the last 15 years and never had any flight experience. So we don't expect you to be able to come learn aviation, learn safety, learn our protocols, our scope, and still be able to act as a practitioner or act as your own medical control. So we put guardrails around and said, if we hire somebody, we're going to hire them as a flight nurse. So we don't hire directly into a nurse practitioner. We want you to get a year's worth of experience under your belt within our program to learn the safety around being a flight crew member and being a good crew member and team member. And then after 1 year, then we will come back, reevaluate, and say, okay, you are a credentialed nurse practitioner. We will start the process and we'll move forward with changing your role and getting you credentialed under emergency medicine as a flight nurse practitioner. So that's how we have been able to kind of mitigate and not hire directly into that, because again, our overall goal is the safety of our crew, the safety of our pilots, the safety of our patients. And we don't want to, as we all know, the ones that have started within this industry, it's like drinking from a fire hose if you don't have that flight experience. And even if you do, sometimes it's a lot of knowledge. You have to dump some from your old program, learn from your new program. And so we don't want to add another level of complexity on top of that. So hire you in as a flight nurse. After 1 year, we'll do an evaluation. They'll meet with me. They'll meet with the rest of the senior leadership. And then we will, if we feel it's a great fit, we'll move forward and get you credentialed. And thus far, we have been able to get everyone credentialed. Now, coming to our, let's say you're a new grad. Let's say you've been a flight nurse for the last 5 years within our program and you just graduated. We will go ahead, so we don't make them do that 1 year deal. We'll go ahead and start the credentialing process because they have been a valuable flight crew member. They understand the logistical difficulties that we can run into. They understand our safety profile. And so with all of that, we've been able to credential those. So even though they're a new grad, we'll credential them and then we'll mentor them with some of the more senior nurse practitioners that are within our program. So moving forward, how we are sitting is right now we're at about 27 nurse practitioners and within the flight and ground program. Now, our program is, our division is pretty vast, and we have different areas that we operate in, or as not necessarily buckets, but we call them service lines. So we have a air medical service line, we have a critical care service line, which covers flight and ground. We have a ALS service line, and then we also have an event medicine service line. Obviously, in the ALS, we don't utilize nurse practitioners, but because we have regional hospitals and they're doing a lot of transports. So where we are utilizing our nurse practitioners are obviously in the air medical, because that's the predominant one that we started with. We also use them in the critical care ground, and we also use them in the event medicine. So when we're doing our event medicine, when we sign contracts with different venues, a lot of the venues, and I'll use soccer since that seems to be the one where we see a lot of individuals that not just the soccer players that get hurt, but people within the visitors. We will have tents set up where we'll do minimal treatment, but we also have a nurse practitioner that is assigned to the treatment tent. And so what we found is, and a lot of it's anecdotal, when we started with it, we weren't sure how this was going to play out, but a lot of it has been pretty phenomenal, and we've been able to reduce the amount of transports, because as a participant that is coming to watch a soccer game, say they tripped and fell, now they've got a laceration to their knee that can't be just band-aided. They need sutures. So what we will do is they'll bring them to the tent. The nurse practitioner will be able to walk through the process, get them sutured up, and get them, an antibiotic if need be. Simple sutures don't necessarily need it, but they're able to do essentially, I hate to use the term treat and street, but that's kind of what it is. It's treat and release more so, and release them back to the venue, as opposed to saying, oh, well, we can't treat them here. We're going to have to load them up, take them in an ambulance to an emergency department where they're going to be able to do the same thing. So we've been able to decrease the amount of personnel that are being transported out of those venues. We've been able to allow us to have the ambulance on station for the ones that actually need to go to the emergency department. And we've been able to help decompress our emergency department, because now we're not sending people that could be treated by our nurse practitioners. So those are our three service lines that are mainly the two service lines, but the three different subsets of those where we're able to utilize our nurse practitioners to the fullest scope of their practice. So that's kind of a high level summary of where we are and how we're able to do the things that we do. We've got support of our Office of Advanced Practice. So within our institution, we have an office that is dedicated to just the advanced practice personnel. So nurse practitioners, PAs, CRNAs, and clinical nurse specialists. So all of the advanced practice fall underneath there. And so they have been really supportive in helping us navigate some of the complexities within the institution to ensure our success. Our executive medical directors, our medical directors, our senior leadership are all supportive, and we try and look for different areas that we can utilize our nurse practitioners to help not just our industry, but also help with our institution. So a couple things during COVID, everyone I think that is medical knows that their hospitals would see, extreme capacity where you're changing PACUs into ICUs. We saw that at some of our regional hospitals, and they didn't have the staff to be able to manage. They had the nursing staff, but they didn't have the APPs or the physicians to be able to manage some of these additional ICUs. So at one of our regional hospitals, our actual flight nurse practitioners actually, because we needed to run providers 24/7, actually did the emergency credentialing, and we staffed their augmented ICU for almost 4 months. In addition to their flying schedules, they would pick up the night shifts, and we were able to staff that to ensure the patients at these regional hospitals were taken care of. And so that's another instance where we've been able to utilize not just the flight nurse practitioners in flight, but also to help almost in a surge capacity where the internal components of the facility were not able to manage the patients that they were seeing. So that's just another example of how we've been able to be so successful within our institution and why we've got so much support. And so that is kind of the high level of where we are. Other things that we are looking at is billing practices and how we can bill for critical care time. We're also utilizing, we've developed a pretty vast SOP for our NPs. And so we kind of give them different buckets that they can choose from to help with the institution. So some of us work additional in the regional emergency departments or the main emergency department to help augment, as you know, across the United States, you'll see these smaller hospitals that are closing. And so everything's getting pushed to the tertiary facilities, and they just don't have the staff to be able to do it. So we're able to utilize some of our flight nurse practitioners to help augment those. Other buckets that we kind of see is a research arm. So we have a research arm where we are trying to do more and more research within the air medical industry, and our nurse practitioners are kind of leading the way, doing different research projects to help our industry, not just from the nurse practitioner side, but just help our industry as a whole. And then we have the event medicine where we're doing those. So we've kind of built a pretty robust standard operating procedure to help not just as a flyer or as a critical care ground transport individual, but how can we help the hospital as a whole? And I think it's been pretty successful. We get a lot of accolades, and the team is just pretty phenomenal. So
yeah, probably
I think it
can have hours of discussion off of that. And some of these questions that we'll ask you will kind of hone into different aspects of what you just talked about. But I think the key thing for NPs to realize, and programs who want to start using NPs, it's not just the critical care transport of it. Certainly that, in my opinion, is enhanced, but I think most programs that succeed, there's many other things they do. Monitor EICUs or all these different things that, it's more than just the transport part of it, and figuring out how you can maximize that the NP role is helpful for making it successful.
Yeah, absolutely. And, the institution, especially in those surge issues, these are force multipliers. And so if you can you're already familiar with your institution, and all of a sudden you see these surges, hey, I can come and I can help. And it really helps decompress the institution as a whole. And I've got some that work in their ICUs as nurse practitioners on the side. So not only do their flight time, but they bring a different level and a different perspective to the units that they are picking up extra in. We have a CCOT or a rapid response team, and a few of our members work on a rapid response team within the institution. And so, those things, they bring a different skill set, different perspectives. And I think we're all looking for our global impacts of of how we're going to help the patients, right? So we're worried about our patients, and so that's the main focus of it. So
Yeah, you talk about credentialing. So both with credentialing and privileging, that's also too the hospital, the organization saying, hey, yeah, these guys are credentialed and privileged with what they do. So it shows that the Vanderbilt health system trusts the providers on there.
Yep. Yeah, there's one other part that I forgot, and it's been around for a few years, and we started it out of our nurse practitioners, which is our shift operations center. So as we talk about throughput from referral hospitals, we have nurse practitioners sitting in our transfer center. And so anytime that a patient is going to get transferred to our facility, excuse me, our nurse practitioners, our flight nurse practitioners are sitting in there, and they accept the patient on behalf of the attending. So therefore, that attending doesn't have to leave out a triage to pick up the phone, delay what's going on in triage, and say, all right, I'm going to do the physician to physician conversation, and then say, ultimately, yeah, I'll take the patient. It allows the ER physicians in triage to be focused on the patient and take care of them, increase the throughput. And so our guys that are working in our operations center are able to accept on behalf of that attending, have that provider to provider discussion, and say, and provide any insight. If sometimes they just call and say, hey, I'm thinking about like this antibiotic versus this. And so they can help guide those discussions. With that, it also helps get aircraft or transports faster. So it's not necessarily aircraft, but we could get ground there faster. As we're having those discussions, we can say, have you thought about transport? Well, no, not yet. Hey, we can send you an aircraft, or it seems like they're appropriate for ground. So we can send our critical care ground team to come pick them up. Okay, great. And so we've got our dispatch center located right next to them, essentially about 15 feet away. And we can go ahead and get that ball rolling, which gets the patient transferred much faster. And so that has been a huge success as well.
All right, let's get into the questions, and then we can build from there. And then if there's other questions in the chat, we'll get to them. And then you have to be done 12:45-ish, right? 12:30. Just let me know, because we can talk all day.
Yeah.
All right. So you kind of already described your experience with critical care transport, but is there anything else you want to elaborate on?
Not really. I mean, my limit for critical care transport had been limited pretty much to the military in Vanderbilt. I was a Nashville native, and so I can remember when we first started Vanderbilt LifeFlight in 1984. I was 16 years old at the time, and I was actually in the hospital. I had bacterial meningitis, of all things. And where the floor for the children's hospital was watched, it wasn't a children's hospital then, it was just a floor within the main institution. I could watch the helicopters take off and land. For those that are old enough to remember, this was also during the time of the Oliver North trial. So I had two things to watch, either Oliver North or watch the helicopters take off and land. And the helicopters taking off and land was more exciting. So from my experience and where I lived, that was one of the driving forces of, I thought this was the absolute best thing in the world to watch these crew members get in the helicopter takeoff, watch them offload, and it was pretty phenomenal. So that kind of started my love with wanting to do critical care transport. So
yeah, you kind of already told us what CT programs you've worked for. It's just been Vanderbilt, correct?
Correct.
I'm curious, are you the only program in your state that flies with nurse practitioners?
We currently are, yes.
Yeah. And then how many years have you been involved in this field?
So I started flying with Vanderbilt in 2006, but within the field, I did critical care transport in the Air Force and in the Army both. So all of it started probably around 1997.
Yeah, this kind of gets me to a question that you were talking about earlier. It's a big transition, like you said, going from inpatient, whether you're a nurse or even a nurse. I don't know so much for a nurse practitioner, but for me, I remember going in from inpatient to flight nurse was huge. And it's
Mhm.
interesting. So your flight nurses, uh, they're allowed to become nurse practitioners immediately. However, if somebody is a seasoned nurse practitioner, maybe they're already have airway experience, central lines patients, they are required to fly as a flight nurse for a year.
Correct. Because we don't want them to have to even though they're learning a new environment. So especially, I'll use if you've been an ICU nurse practitioner for the last 15 years, you are phenomenal when it comes to managing critical care patients in the ICU. ICUs have a lot of resources. You don't have those resources when you're in the back of the aircraft. It's just you and your partner. So we don't want you to have to concentrate and worry about that part when you're still trying to be a good crew member and learn the dialogue and learn that, hey, there's safety aspects that we have to take into consideration when we're flying that I don't necessarily have to take care of when I'm in the ICU.
Yeah, it's interesting because that's kind of how students ask me all the time. And when they come through the program, I'm a very straight shooter. You cannot have 1 or 2 years experience as an ICU nurse, expect to go through a year and a half of school, and then come out there and be the leader on a transport team, because not only are the flight nurses looking to you to bring more to the table, um, but it's a whole nother environment. So I always tell students that you either need to have one or the other for sure. Either lots of experience as a nurse practitioner, you can put in lines, you can intubate, you know how to take care of patients, and maybe you can learn the logistics of flight. Ideally, you have both. You
Mhm.
have been a nurse practitioner for several years, you know the logistics of flight, and you're also a nurse practitioner. To me, that's the top candidate. And then I don't know, but I weigh in my mind what's more important, the transport experience or the ICU experience. And I think they're both important. So if I had my choice of candidate, they would have both. What do you think?
I would agree. And especially as we're doing more, we're finding, or at least within, I'll talk about our geographic region, we're finding more and more hospitals are the referrals. We're seeing a decrease in the number of scene calls because essentially they're doing load and goes, unless they're going to be a prolonged extrication. We are seeing them take them to the emergency department. They don't have enough EMS personnel and enough ambulances to go out of county to get to the big regional hospitals where they need them. So they're taking them to the local ER, knowing that they may not be able to manage them well, but that they can get the resources that they need. So we are seeing more and more of those critical care ICU, ER type stuff as opposed to what we were really seeing 15 years ago, which were more scene calls as opposed to interfacility transports.
Yeah, the other thing, when you are flying or transport anywhere, it's a very resource. There's not many resources. So
Mhm.
everybody that's there, whether they're a physician, nurse practitioner, nurse paramedic, they need to know logistically how to get it done. Because just, when I work the ICU, it's a bunch of orders, do this, this, and this, but that doesn't work when it's just one other person. So you two have to get it done.
Exactly. And that's the reason why we want them to be good crew members first, because you got to work on that communication. You've got to work on, I know some great nurse practitioners, but they're the ones that are, all right, I need this done. I need this, this, and this. They're putting in all the orders for stuff. But then the nurse is the one executing it. Well, you don't have all of those ancillary and additional resources. So not only are you the one, if you're going to be your medical controller, saying, hey, I think we need to do X, Y, and Z and do this, but now you have to be the one implementing it, not just putting in the orders. So
Right.
it in a resource poor environment, and by resource poor, you don't have multiple nurses that you can pull or medics that you can pull. It's just you and your partner. Because of that, that's why we need them to be good crew members first and get that down pat. And then, then we can take advantage of the additional knowledge and experience and skills.
Yeah. Tanner, you have anything else to add here? Questions before I move on? So Tanner is a long-time flight nurse. How long you been a flight nurse, Tanner?
5 years.
Yeah, he's in our program, and he's in nurse practitioner school, so he wants to be a flight NP. You have any questions to add to that?
I know we did have some questions in the chat that maybe could be addressed now. But I think it's really interesting taking people, even seasoned flight NPs, and really taking your time and making them a good crew member, flight crew member first, before transitioning to that advanced practice role. So that's interesting. And that's not something I don't think other people are doing. And so that's a really interesting take on it. And I like how we talked about kind of the differences, and I think we'll get to that next, how you treat pediatrics. But I think there's a couple questions in the chat that are relevant.
Can you read them? I don't want to mess up the screen here.
So Jacob Miller, who will also be one of our guests later in the semester, says, I'm curious how the ENP certification is recognized by the Tennessee Board of Nursing. I realize scope of practice is set state by state, but in Ohio and Kentucky, ENP was not recognized when I was flying, since it's only a specialty certification under the LACE model, not its own population yet. For my practice in Ohio and Kentucky, we were required to have PEDS ACNP to manage pediatric patients. So looking, is the ENP certification recognized by the Tennessee Board of Nursing?
So it's kind of like it's not recognized by the Board of Nursing. So to be an ENP, you have to have FNP on top of it. So FNP, because it's population based, ENP was an additional, but what the ENP program brought along was some of the the specialties that come along with emergency medicine that you don't necessarily get in family practice. So that's why we kind of went with that model to start with, was, hey, we're going to do FNPs because in Tennessee, FNPs can work in the emergency department because they do the from birth to death. What we wanted to add to it was the ENP, because we wanted them to have that emergency medicine additional experience. And so I know at some point they're discussing, right now we're in discussions right now about making ENP a population based, which has got its good and its bad. But with that's kind of how we landed on it, was, hey, FNPs, but we want you to have that ENP. And there's different ways to get your ENP, right? So you can have your 2,000 hours of experience working in emergency medicine and then take the exam. Or you can go through a traditional postmaster's certification and get your ENP. So we just felt that if we want to be an industry leader in showing that we are trying to cover the gamut of being able to take care of these patients, we wanted them to have their ENP on top of it. I hope that answered the question.
He has just a clarification on that Ohio and Kentucky Board of Nursing say that FNP is primary care only, and ENP cannot expand the scope of practice into emergency or acute care. So does the Tennessee Board of Nursing, if I'm asking this correctly, Jacob, allow the FNP to act in that acute care environment, or does that ENP
Yes.
allow you to act in the acute care setting?
No, the FNP, actually, they allow them to operate in the acute care settings.
Awesome. Thank you. Greg, I see your questions here. We're actually going to get to some of that in a bit, so we'll kind of circle back to you. And then Dave Holloway, who is going to be a guest on this series as well, come late February, a member of the Cleveland Clinic Critical Care Transport Team, so another local program. He's got a question that says, have you experienced any challenges with recruitment of experienced critical care NPs due to requiring them to step into a flight nurse role for a year? And I'll add on top of that, during that year period, are they being paid as NPs or as nurses?
Okay, so I'll address the second part. So no, they are being paid as a nurse because that is their job description. And we have not seen we still have a lot of nurse practitioners that are applying, and we explain it to them on the forefront before we even get to the interview process of because that is our standard. That is what we want. We want good crew members, safe crew members, and we don't want them having to do any focus. And thus far, it has not deterred anyone from applying or getting hired. And so we've actually hired some really great nurse practitioners with a lot of experience working in either ICUs or working in emergency departments that have a lot of experience, and they truly understand of this is our standard. We want everyone to be safe, and we want everyone to be crew members. And if that means that we have to take a step back to do that, that's just how we are going to evolve. And we don't want to rush anything. So I hate to use this term I use a lot in the military is slow is smooth, smooth is fast. And that's how we want it. We're going to grow our program, but we're also going to do it safely. And I think that's how we have been able to do it thus far safely. And when we first started this, we only had 11 NPs, and now we're up to 27. So
Keith,
wow, 27.
Keith, I can see this in a lot of people's minds. Now, if they were a senior flight nurse somewhere else in the country and they become an NP, would you make them, do they need another year at your program, or just like say CFRN or some sort of background that says, hey, I've done this critical care transport?
Right now, we are still making them take a step back, and because we want to do it safely, and every program is not, I may have a lot of experience. Let's say I've got a lot of experience at Vanderbilt, right, since 2006. But if I come to the Cleveland Clinic, now I've got to learn how the Cleveland Clinic does it. I've got to learn their aircraft, their roles. And we know that can't be done overnight. And so Vanderbilt's got a lot of nuances, I think, as most academic institutions are. And we want you to focus on being well-grounded before you take that next step. And we're not penalizing anyone. It is that we really, really value our culture and our safety culture. And that is what we are trying to protect. And we're trying to protect our patients. And so that's the goal behind it.
I would imagine the flight nurses and flight paramedics really appreciate that.
It does help because
it makes sense. They have to know. Yeah, it makes sense. No challenges filling your vacant positions?
Not thus far. It's like everyone else. It's not so much that we're a revolving door, but when we have vacancies, usually the vacancies operate because someone has applied to medical school, or someone has been flying for years. And let's say we've had a few that have graduated that said, I want to go, I've been flying for 20 years, and I graduated as a nurse practitioner. I'm kind of done flying. I want to work, in a clinic, or I want to work in ICU, but it's never, we don't have them necessarily leave because it's like, I just can't stand this program. We've been really fortunate to have really good candidates. We got really good team members. And so I can't talk enough about our program, but there's a lot of other programs that are out there that are just as well. We've had a few. I had one of our critical care paramedics who was absolutely phenomenal. Didn't want to leave, but had to leave because his wife just finished residency and got an attending physician out west, and he's like, I can't commute. And I was like, I understand that. And plus they were having a baby, so I totally get it. Life happens. But
Yeah. Hey, Tanner, I think we should address this question one of Craig Zanone. I hope I said that right. Do we talk
all right, and then
because it's a really good question, and let's address it now because it's a big question out there. And Greg, we write to this in the upcoming publication. So the question is, how did your organizations go about having the conversation about utilizing nurse practitioners? I think we're having trouble convincing our bosses or system that the costs are justifiable.
so again, we had our Office of Advanced Practice, we utilize them heavily because they are super supportive. So let me give you a little bit of a background of Vanderbilt. Vanderbilt is an academic institution, like a lot that are on here. It is a large nurse practitioner or advanced practice. So we'll just leave it as advanced practice because we've got our PA colleagues, our CRNA colleagues, and clinical nurse specialists. So we are a very advanced practice driven institution where the advanced practice providers manage pretty much every unit that they have. There's attendings, residents, and there's nurse practitioners for every service at Vanderbilt. So we're driven, as you can imagine with a residency, right? So your emergency medicine, hey, guess what? I'm down in the emergency department for 4 months, and now I'm going to start my rotations. I'm in trauma for 30 days. Now I'm going to move on to surgical critical care for the next 30 days. Then I'm going to move on to the MI for the next 30 days. So the consistency, there's two consistencies. One is the attendings and the other are the nurse practitioners. So we are very driven as an institution that is being very supported by our nurse practitioners. So having that discussion and getting Office of Advanced Practice as a buy-in just helped us even more across the institution. Now, our nurse practitioners currently in flight do not bill. So within our department, they do not bill. However, within the rest of the institution, they are billing. And that is what we are looking at, is how we can implement the critical care billing practice to help augment, our income per se on the billing side of the house. So those are things that we are looking at. We haven't set anything in motion, but we're looking at how we would go about that. And our Office of Advanced Practice is unbelievably supportive in that, and they can help us navigate some of those nuances that we run into. So it is a financial undertaking, but with that, if you think of a flight program, when we started first flying with residents and attendings, and they would show up at the hospital or they would show up at a scene, and they're like, oh my gosh, y'all got a flight physician, y'all got a physician that's flying with y'all. And we get the same thing from the nurse practitioners when you show up in an emergency department and the nurse practitioner is like, hey, and can help navigate, get the patient accepted, can help navigate managing the patient. And we've seen overwhelming success with that, and the support from the outlying facilities. They love, not that they don't love our flight crew, but when an advanced provider or a physician shows up, they just feel, hey, like, I know we're being well taken care of. The patient's being well taken care of. They're a great resource. And our flight crew members, whether it be our paramedics, our critical care paramedics, or our flight nurses, we work as a team. It just makes our team that much stronger.
Yeah, that kind of leads to the second part of his question. You mentioned critical care time. Do you guys bill critical care time throughout the flight? How does that work? How does it work with reimbursement from insurance companies? I think what we should say is it works different in every state, which is the big challenge. We talked to this in the publication, Greg. My opinion is the United States needs to figure this out at the high level, but you are doing critical care interventions, the same interventions you would do in the intensive care unit. The same thing I do in the intensive care unit, I'm making the same decisions in the helicopter or wherever you're working. So we can't get into the details of that, but critical care time is being billed and should be billed. All right.
Yep. And
Quickly-
currently we're looking at trying to navigate that and figure out, it is state driven. So what insurances do you have within your state? What do you have to do for Medicare, Medicaid? And so we're trying to navigate that now and look into it and figure out like exactly what we need to do.
Again, opinion here, but the argument is if you're going to put a provider, whether that's a physician, NP, or whoever on board, if you increase your lift fees, that cost is justifiable, so there's a lot of ways to probably navigate that, and probably some creative thinking. Like, we're at the forefront here. I hope I can define it in a couple years. We'll see.
Very quickly.
Yeah, go ahead.
Just there's some secondary questions. So hopefully, Greg, that answered questions 1 and 2. Question 3 we'll get to. Question 4 we'll get to. Maureen, that's part of his question 4. We'll get to the training and whatnot. Very quickly, Keith, can you talk about the Office of Advanced Practice? What do they, can you describe what they are real fast? There's some people wondering.
Oh, yeah. So our Office of Advanced Practice, so there's like most institutions, we have executive nursing officers. Well, we also have one for our Office of Advanced Practice. So we have a director that's the high level over all of advanced practice. And then we have other directors underneath him that are for CRNAs. We've got them for different for the acute care side, for the intensive care side. They all have different directors that fall underneath them and they roll up. And so the Office of Advanced Practice basically is the interface between the facilities or between Vanderbilt and all of advanced practice. So the advanced practice individuals fall underneath the Office of Advanced Practice. And so they are the ones that communicate at the executive level within the institution and help kind of drive those. We also have different committees that fall underneath the Office of Advanced Practice. So we've got an Advanced Practice Council. We've got used to be a protocol committee, is kind of the one I chair, but it's not really a protocol committee anymore. They're the ones that manage our protocol warehouse, where if the state comes in and they want to do an audit, we have a whole protocol warehouse that everyone, depending on what department you are in, they can sit there and it's all computerized. They can sit there and click on it and they can see all the protocols or clinical practice guidelines that you have that you are following. So it basically makes sure that we adhere to all the guidelines through CMS and makes sure that we adhere to all the guidelines within the state, the federal guidelines, and then within the institution in our bylaws.
So just to summarize, they sit at the kind of executive level, and they are a senior leadership that understands what you do and can liaise with other hospital leadership to really make things happen.
Absolutely, and everyone that's in there within the director level, they're all advanced practice.
Excellent. Thank you so much. And then we do have one question that I think a lot of people are wondering. This is from Rob Grabowski. He's the chief flight nurse practitioner at Metro LifeFlight here locally in Cleveland, and he asks, for the NPs in the transfer center, is this a rotational shift, or are they on call in a clinical capacity, i.e. at a flight base or at the hospital? And do they only accept for emergency medicine and accept ED transfers, or will they also accept for other services like the ICU? Are there any conflicts with ED attendings for accepting certain patients, particularly with injury pattern or ED volume? And then I'm going to supplement his question with, do the NPs determine the mode of transport for which the patient is transferred?
Okay, so that's a lot of questions.
It's a whole lot of questions
in there, but all right, so I'm going to try and answer them all one at a time. So they are not, so we have a separate schedule, and so they go in and it's 8-hour shifts. And so they are not in a flying capacity when they are working. So I have a lot of our nurse practitioners that we call 50-50. So they'll do 24 hours on the aircraft, and they'll do 16 hours that week in the transfer center as the shift operations center. So they'll do either a 16-hour straight or 2 8-hour shifts that week. So it's fully staffed, but they're not in a flying capacity on that day. It is considered clinical because they are making clinical decisions or assisting with clinical decisions. So those are what we would consider clinical hours that they are actually working. So completely separate, because we want to ensure that that is managed completely different than the flying aspect of it. Because if you're on call or if you're flying, you may not be there to help when they need you. So we made those two completely separate. The next thing is they don't decide the mode of transport. They can they will have a dialogue with the referring facility, but under EMTALA, the referring facility can choose the mode of transport and who they want to go with. What they can do is say, hey, by flight criteria, they meet flight criteria. If you would like for us to send an aircraft, we can. Or, hey, this patient fits the ground criteria. And so we have different criteria that are all spelled out, and they can go down basically the checklist. Or, hey, they meet the criteria to go by ground. We have a critical care ground transport team that we can send that way if you would like for us to go ahead and get them on board. But for those individuals to sit there and say, no, we're going to send an aircraft, or no, we're going to send a ground, and we're going to send our team, is an EMTALA violation, because it's up to the referral to be able to choose the mode and who they want. So, but we do offer it. Hey, you don't have to pick up and make a separate phone call. We can go ahead and activate ours if you would like.
Okay, thank you for that. And then real quick, do they accept like ICU transfers or just ED transfers?
No, they can do ICU transfers. Now, we do have some specialties. Pediatrics, the pediatric goes to the pediatric transfer center. So we don't deal with the pediatrics. And cardiac, we have gotten involved in some of the cardiac, but the cardiac fellows and the attendings want to be involved. So we do kind of listen into some of those conversations and can help if need be. But there's some services that are absolutely like, no, we want to know everybody that's coming and not be as involved. So we're on the periphery to offer any assistance.
Okay, thank you, Rob. I hope that answers your questions. All the other questions I think we'll get to here in the next little bit. That's all the questions in the chat for now, Dave.
All right, so you said you're both family and acute care, correct?
I am, yes.
And you are not qualified in PEDS, or you are?
I am under the state guidelines as a FNP, yes.
Yeah, okay. Now, what would you do? Because for me, for example, I'm only qualified to see adults, so I function as an RN when I take care of somebody. In Ohio, it's under 14.
Okay.
So are all your NPs required would that be acceptable at your place? Like, only can see adults, no pediatric? Okay.
Yeah. We have a few that are acute care, and they were actually in acute. They went through the acute care intensivist program, and so they will see ages 16 and up. And if they do see pediatrics, they revert back to as they would an RN and utilize the pediatric medical control.
Yeah.
One of the things that we do, so we have our own pediatric hospital, and they have their own ground transport. So a lot of the interfacility transports they wind up doing. Sometimes we do them, but we have noticed a decrease in since we have our own pediatric transport, we have noticed from our flight side a decrease in the amount of pediatrics that we're actually transporting.
Yeah, I think everybody probably has opinions on this. I think when you're taking care of the little ones, or adults for that matter, just because you have a license doesn't mean you're, in my view, because completely competent, so
Mhm.
even if I was a pediatric NP, if I didn't see peds all the time, I would want, with me on the transport anyway, somebody who was dealing with these, young ones or neonates or all that. And
Oh yeah, absolutely. We still communicate very well with our peds medical control, because you'll get something like a X deletion syndrome where you're calling the pediatric emergency department and you can hear them typing as they're trying to look it up, because they're like, yeah, I've heard of it, I don't remember it, and they're feeding you the information on the outbound leg. So you can't be a master of all, right? So we do, even though we are allowed to and can be. I have some great flight nurses that were pediatric nurses for years in the emergency department in the PICU. They went back. They went to like the acute care program or the FNP program, and they've got years of history of pediatrics. And they still are like, well, this I can do, this I'm not as comfortable with. I'll load the boat. I'll use peds medical control, when I don't feel like this is something that I have seen a lot of or can manage. So we don't say it's the end all be all because you're the practitioner or because you're the physician that's flying, that you have to be your own medical control. You can reach out and ask questions, obviously, at any time. So, and we have that.
okay. Another question at the bottom. So I guess the first question I have, would you allow a nurse practitioner who is only family nurse practitioner to provide care as a nurse practitioner on your team? Or do they need the ACNP certificate and the family is a plus?
No, we let them practice, but again, it goes back to you have to be a flight crew member for a year, and then the training, the scope of practice, by the state licensure, FNPs can work in the acute care setting, and so in emergency departments. So we do let them function in that role. But a lot of it is discussions with them about their comfort level, what you feel that you're able to do, what you're not able to do. And then we have essentially experts in every field at Vanderbilt. And so if they feel like they need more additional education or training, we will get them the clinical aspect that they need to make sure that they are comfortable and competent.
Now, this is where there will probably be differences in state
Yes.
regulations based on what the nurse practitioner can do. But I'm curious, and there's a question here. So are FNPs allowed to work in the ICUs in Tennessee or at Vanderbilt?
At Vanderbilt, they are not, and it's not that they're not allowed to. It's that we don't, because we have the acute cares that are historically trained to manage ICU patients. So the FNPs, as a general rule, do not at Vanderbilt. They work in the emergency department and urgent care and the clinics, and then we have them on the flight side.
Have you been able to see any advantages or disadvantages of the FNP degree versus the ACNP? And I guess if you were advising somebody who's just starting with one, which they should choose if their goal is to be critical care transport?
So a couple things. So that's a tricky question, but I'm going to try and answer it the best in my personal opinion. The state of Tennessee authorizes or allows under our nurse practitioners as FNPs can work in the emergency departments, just not in Vanderbilt in the ICUs. So what I would recommend if somebody was going that route, I started out as acute care. That's kind of where my love was, but I also wanted to be able to see pediatrics and be well qualified in all realms. Not trying to be an overachiever, but I just wanted to be, the best that I could for my patients. So that's why I went back and did a postmaster's. What I would suggest is probably check with what you are able to do within your state. So I think someone alluded to, in certain states, FNPs cannot work in emergency departments or ICUs, and they can't do acute. They can't work in any acute setting. They can only work in clinics. That would probably preclude me from going that route. If I wanted to fly, I would probably go the ACNP route. What I would say is, I'll use Vanderbilt because a lot of our flight nurse practitioners have gone to the Vanderbilt program or other programs where they get to choose their clinical paths. And so some of the clinical paths have been either in urgent care or emergency departments. And so I would direct them, if that's what you want to do and you want to do family, then go that route and make sure that some of your clinical time is spent in urgent care and emergency department settings.
Yeah, I think everybody is entitled to opinions on this. And what I tell people, at least at the institutions that I'm familiar with, their educational background, mechanical ventilation, hemodynamics, shock, procedures such as lines, chest tubes, airway, those things are 100% taught in the ACNP realm of education. And I don't know if that's taught in the FNP realm. My hunch is not always, but I don't know for sure. So I would advise students, and I do advise them, to take the ACNP route, understanding that they are going to have no education with the pediatric population. So they have minimal, I mean, that's where their gap's going to be for sure. And whether that's right or wrong, I don't know. That's kind of my opinion on it. And that's why I asked you. I'm going to get to, this is a pretty heated topic sometimes up here anyway, and then we'll see everybody's opinion on it.
Yeah, no, I would agree. It is a very hot topic. And that's why I was really supportive in the ENP program. If it becomes a population, I think that is the perfect niche for flight medicine, because it incorporates peds, adult, and kind of the critical care things that you would see in the emergency department. Not per se the ICUs, but as you know, more and more hospitals are treating ICU patients in the emergency department, and they're having to hold on to them because of bed capacities.
Yeah.
So
and
that would be my
probably,
hope. But
probably I have some bias with that feeling, right? Because I'm an ACNP. That said, if we're doing the treat and street thing, that's probably not something I've done a lot. So I'm sure the FNP would be better at that. So I don't know. Get a lot
With
of
the expanse of your
recommendations.
program,
Get a
you can
lot of
kind of explore
recommendations
everything.
is what I would say, and go with what your gut tells you. My
Yeah.
recommendation would be ACNP
Yeah.
first, and then FNP.
Yeah, no, I agree. That's how I did it. And not to say that I'm right or wrong, or anyone else is right or wrong in the way that they choose it. What I would encourage everyone is, whichever route you go, if you want to do this, I would say when you're doing your practicum or your clinicals, try and get in either an ICU or an emergency setting, so you get some of those experiences and work with clinicians that are doing it every single day. So for that semester, and sometimes it takes, if you're in an FNP program, you may have to go to the director of the FNP program and say, look, these are my goals. This is what I want to do. Can I deviate a little bit from doing a family practice in a clinic for this semester? Can I do emergency medicine, or can I do the ICU? And I think that most program directors would say, well, you have to meet certain goals. There's certain objectives that you have to meet. But I think that we can make it work somehow to fit you. But it's having those discussions early on with the program directors.
Yeah, I mean, I'm sure there's a lot of FNPs that can easily pick up a book or get a couple experiences and figure it out, even without the ACNP degree,
Mm-hmm.
All right. I think we're good. can you speak about your path and preparation to CCT as well as your clinical background? I think you kind of already gave us that. What specific training do you recommend to prepare for a NP role in CCT? I'll say that I get this question asked more than anything. And also, I think while you're at it, you should address even a flight paramedic, flight nurse role, like kind of all encompassing here. Both start with the NP, but also for somebody who might want to be a flight nurse on your team.
So, specific training for the NP role. So, we have a lot, for somebody that wants to be on our team. We always want people to have ICU, PEDS experience. So what I recommend is if you're going to be a flight nurse practitioner, you've got to have a good foundation as a nurse, right? So anybody that goes through school knows that. So we want them to have experiences in the ICU, and we want them to have experience in the PEDS. And so what we have tried to do is say, hey, if you get a lot of PEDS experience in the pediatric ICU, then you need some adult experience as well, but you're going to need it in an emergency department, because that way you know what it's like to operate in the ICU. You also know what it's like to operate in a emergency department, and you've got a little bit of experience with your PEDS side of the house in the ICU, so you know what it's like when somebody from the emergency department brings it up. Same sense of working in the emergency department. So yeah, you see the acute side of someone coming from an adult coming into the emergency department, but there's also those things where, hey, you're going to get some ICU experience because you may have to start them on drips. They may have to sit down there for the next 48 hours in the ICU, because the ICU is full. They don't have a bed, so they're stuck down there. So they get some ICU experience. And also when they go to the ICU as a transport, they get to communicate. They get to see what the ICU is like. So we try and get them to have a whole well-rounded experience. For the NP, for the nurse practitioner, we don't necessarily want them to have the ER experience or the ICU experience. We want them to have just a well-rounded experience as a nurse, and then as an NP, we'll grow them. I hope that answers the question. I can't say that as an NP, I want you to have only worked in the emergency department, because we're going to see those patients that have worked in the ICU. Now, if you were an ICU nurse for 15 years, and now you are working as a nurse practitioner in the emergency department, that's even better, because now you've got ICU and ER experience. Does that make sense?
It does. So I'm curious, side question here. Do you also, who's in charge of hiring the flight nurses there where you work? Is it you?
So we have a peer interview process, and then we have a leadership interview process. And so our immediate leadership team is made up. So each base has flight crew members. So whether it be nurse practitioners, physicians, critical care paramedics, or the NPs or nurses. So we have those at each base. So they're staffed at each base. There's a chief flight nurse. The chief flight nurse rolls up to myself and my counterpart, Sheldon Dreddy, who's also a FNP. So we kind of broke it up into regionals, and then we have a director, which is Kevin Nooner. So when we do the leadership interview, so they go to a peer either recommends them to the leadership, or they'll say, hey, they're not at that level yet. We've given them some recommendations, and then they are allowed to, obviously encouraged to reapply, but get some of the experiences that they need. When they come to the leadership team, it's the chief flight nurses, myself, my counterpart, and our director. And then we do the interview process, and then based upon feedback, the hiring managers are essentially myself and Sheldon Dreddy, and then we consult with our CFNs through the interview process and kind of do the score sheet and talk about, yeah, they'll be a good fit, yeah, they've got some great backgrounds, but ultimately the hiring managers are myself and my counterpart.
Yeah, I think a lot of nurses are looking to become flight nurses, ask this question. And I always tell them they need to get experience with ventilators, ICU drips, A-lines, central lines, Swan-Ganz catheters, chest tubes. So my advice is generally to sway them towards the unit. Is that your preference for flight nurses, or do you, again, Vanderbilt ED may probably see all that stuff. I'm not sure a lot of regional hospitals would see that stuff. What do you think?
We do. So if they have worked in the big Vanderbilt system, they'll see a lot of ICU patients that come through, and sometimes they're boarded down there for 2-3 days until they can get upstairs to a bed. But if they're coming from a regional, we want them to have a good experience because it's a double-edged sword. If you're in a resource poor environment, i.e. you work out at a primary emergency department or a freestanding ER, you don't have near the resources that you do at an academic institution. So when a patient comes in, you kind of got to be the jack of all trades and kind of manage until you can get them transported out. Those are some really great experiences to have, and that's some really good knowledge, because when you're flying in the back of an aircraft, when I say resource poor, I can have all the fancy equipment, but I don't have the personnel. So I have to learn to manage all the different things myself, or between me and my partner. So in those instances, those are some great experiences. But you also, when you get to these tertiary facilities working in the ICUs, you're going to see things there that you've never seen before, because local smaller hospitals aren't able to manage it because they may have never seen it before, or they don't have the resources, and I don't want to say they may not have the specialties to be able to manage it. So we try and encourage that they get some of those great experiences at these academic or the tertiary facilities. ICUs are definitely one, but here's some of the downsides when you go to those. They get so specialized. So if you work in the trauma ICU, you see a lot, not just trauma, but all the comorbidities that go along with the patient. So you get a lot of different experiences. But if you're strictly cardiac or neuro, you got some great experiences with cardiac and neuro, but that is like your sole focus. Granted, they have other comorbid factors that go along with it, but you're strictly dealing with a lot of those specifics. So we try and get people to be well-rounded. And if not anything, if you're like, no, I've dedicated my time to the neuro ICU, that's where I really enjoy. We also encourage them, hey, take advantage of some educational opportunities at other units, or educational opportunities that we offer, to try and get them some of those experiences and some of the knowledge.
Yeah, you're right. That's the drawback of the academic institution ICU. If you're a CV ICU, great, this, if you're neuro ICU, a lot about neuro, but how about STEMI and all that other stuff, and trauma. All right. What qualities or characteristics make a strong APRN candidate in CCT, whether they are a new hire or an experienced NP? I will say, we talked about this earlier, Keith. We're doing a survey on this.
Mm-hmm.
We're surveying the crew members of these institutions. The doctoral student will put it for some sort of poster, and then we're going to publish this in our medical journal and put it out there.
Yep.
So, but we can take your opinion still here on what you think makes a good APRN and CCT.
So I think, and again, this is my opinion, what makes a great APRN candidate is the ability to be able to help educate, but also learn. we all come with different experiences. We all come from different backgrounds. And just because you are the APRN doesn't mean that you know it all. I've learned a ton from some of my critical care colleagues, whether it be the critical care paramedics or critical care nurses. And they come with different experiences. So I think that is one of the qualities, is being open and receptive, not to other people's knowledge, other people's perspectives, because there are, one of my chief flight nurses is a great friend of mine, Wilson Matthews. I did a cave rescue back in 2012. Yeah, it was 2012. As a flight crew member. And so this gentleman was about, if I can remember, it was about 1,200 feet into the cave, through all these navigations, and started having a stroke. So his partner that was with him had to get out of the cave, called 911, EMS got there, we got there. We had to go into the cave, wound up in this tiny little thing. We wound up intubating him, getting him into like a Stokes basket and trying to get him out, all the dark. And we got him out up the side of the cliff, got him loaded in the aircraft. We got him there just in time. They did a thrombectomy and he was neurologically intact. I had Wilson, who had been doing this for decades. He goes, well, that's one thing that I've never heard of or never done. So I think those are experiences that, and I was a flight nurse at the time, even though I had the APRN, I was still a flight nurse at the time, but those are experiences. And that if somebody else got called, I could explain to them, hey, these are things that I learned from that. So I think that that's probably one of the great characteristics is being open and willing to look at other people's perspectives and being able to be a good teacher. Because ultimately, I've got me and my partner on a flight, and it's just the two of us. So if he can help educate me or she can help educate me and I can help educate them, it just makes us a stronger team.
Yeah.
To piggyback off that, you talk about you and your partner. Do you guys fly a combination of nurse practitioner, medic, physician?
So in the state, all right, so we fly it. There has to be a nurse on the aircraft. So obviously, as a nurse practitioner, you still hold a nursing license, so that counts. So that counts. So it may be nurse practitioner and critical care paramedic. It may be nurse practitioner nurse or nurse practitioner physician. Physicians have to fly because there has to be a nurse on the aircraft. So there have been instances where it's been a nurse practitioner and a physician flying. So physicians unfortunately cannot fly with our critical care paramedics because that's our state guidelines.
Thank you.
Excuse me.
Here's a question. Do you feel that NPs that are previously paramedics have a better grip or knowledge on CCT? Being both, I feel that there should be some requirement to ride in the ambulance, seeing the initiation of EM in a mobile environment versus a controlled environment. Do you have any protocols on that, and what is your opinion? I think from what you told me, basically the nurse practitioners have to be comfortable a year as a flight nurse so they would get all those experiences.
Correct.
And I have to say, I agree. I think the foundational background is that experience in the squad, in the unorthodox environment, that is super helpful for the transition. And it'll be interesting to hear the other interviews' opinions. I think there's a lot of challenges coming from only inpatient to now the transport environment.
Oh, definitely.
It is doable. However, you can't be a novice at both. So it's unlikely brand new nurse practitioner, not much ICU experience, and no critical care transport experience is going to move directly into this realm.
And one of our state guidelines also requires that you have your EMT. So to be on the aircraft as a nurse, you have to have your EMT license. So they've had to at least go through the EMT program and get some experience and some exposure to ambulances.
Yeah.
But we do encourage it, and we encourage especially candidates from inside the hospital that really have no prior EMS experience. When we are onboarding them, we will get them some EMS experience if they don't have any, other than just going through their EMT. We look for areas of opportunities for improvement. And so if you show up and you've got all this great resume, you knocked it out of the park, we offered you a position, but you don't have a lot of EMS experience, we'll get you that EMS experience during your orientation process. So that does help, especially while they're on what we call our third rider process and going through the clinical aspect of the hospital. So they'll spend some time in the trauma unit, they'll spend some time in the CVICU, they'll spend some time in neuro, spend some time in the ER, and then we'll get them some time on the ambulance to work with our counterparts so they get some of those experiences.
I'm interested in this, and if anybody knows of any, please email and let me know, because I'm aware of 3. But do you know of any other CCT programs that use APRNs in their crew configuration model? So I know of you, Vanderbilt, Metro LifeFlight, who's now taking, that may expand a little bit, and then the Cleveland Clinic critical care transport team. Do you know of any others?
Those are the only 3 that I know. I have had different programs reach out and ask. Oh, it looks like Trans Aero Medevac in New Mexico. Great. Nebraska Children's.
Yeah, if you know, put them in the chat, please.
Yeah, please.
Yeah, please do.
Because I've had other programs reach out and say, hey, how have y'all been successful at this? And so I'm open and talk to them about our processes and how we've done. Some of it comes down to, you know, as much as we hate to admit it, healthcare is a business, right? It just is, right? So we have to be cautious, or we have to do our due diligence, and you know, things are expensive. So we have to take that into consideration as well. And some programs are looking at adding advanced practice, but they feel it's cost prohibitive. So I've given them some ideas to go back with. So you know, that's where we are right now, you know, and you know, maybe at some point legislation will change and they will the reimbursements will go up for the things that we offer. You know, billing critical care time may help augment, but it's still, you know, it's in its infancy, as we've all are aware. That's why we're hosting some of these things. So
yeah, I think, and we talked about this offline yesterday, you know, maybe it doesn't make sense for every program, right? I mean, if you do a flight every 2 days, you know, maybe that doesn't make sense. So I think where, it's yet to be defined. And I think the other thing that NPs and students that like come through the program need to understand, you have to add value, right? So that means part of it is defining and describing the value you bring, whether that's, you know, help monitoring the ICU instead of physicians, but a lot of it's offloading physician work, right? Triaging these calls, like you said. Instead of EMS calling, let's say, the ED med command, why not call an NP that does transport, right? So there's a lot of opportunities, and then defining them, but it can't be you just make more money as an NP and sit at base all day, right? So even the NPs who want more money need to understand that we have to bring the value, you know, and define it.
And that's what we've tried to do with our SOP, and get them involved in being leaders. And so, you know, hey, you know, I'm speaking for Vanderbilt, you know, being a huge academic institution, we love research, we love publishing papers, and being on the forefront of that. Hey, I've got some really great NPs that love doing research. Hey, we're going to get you involved with it, because that is value add. That brings things to the institution. Working in our regional, you know, working in our shift operations center, all those things are value add, and that's what we are looking for. Of not just clocking in, clocking out. If we're going to practice at a higher level, we've got to do value add and bring things to it, just like our physician colleagues within the institution.
Yeah, and these other Zooms will have the value add that those programs are doing as well, and all these ideas, you know.
quickly, you said that the pediatric team at Vanderbilt's a separate team.
Correct.
Do they use NPs?
So our neonates do. They do
Okay.
have the neonate nurse practitioners that go along with them. The peds ground team does not.
Is there a peds air team, or do you guys
There's
do
not. We do
air?
we do the air side. Yes.
Okay, thank you. And just time check, it's 12:30 if anybody's got to run.
I think we're nearing, yeah. I think we talked about your pediatric experience. How important is pediatric experience, and how can a candidate strengthen their resume? I think we talked on this.
Mm-hmm. Yeah, the biggest way to experience it is even if you I hate with work-life balance, you don't want to say, hey, pick up extra work, but to get some of those pediatric experiences, the best way to get some of those are working in your pediatric emergency departments or pediatric ICUs at your pediatric hospitals. If you don't have a pediatric hospital, I would say to get some of those experiences, find an emergency department within your geographic area that sees a high volume of pediatric patients, because that will help strengthen your experiences with the pediatric population.
Yeah, I think a lot of this is going to be program dependent. I know programs where the majority are adult NPs and they pretty much fly adults. That said, they have a pediatric specialty. I think everybody needs to know how to manage the 1, 2, 3, 4-year-old, that the common things that happen frequently, because there may be a chance where the pediatric team is unavailable and you're it, so I feel not everywhere that people have to be pediatric experts. What do you think? But they have to know how to transport safely a kid on a ventilator and not blow their lungs out, not that they're going to
Yeah, absolutely. No, that's a huge thing. Is like, there's certain standards that they need to have and experiences that they need to have. I use the X deletion syndrome. Like, I don't need you to know that. I don't even, only because of a transport, but and having those resources that can help you as well. So like we use our pediatric medical control, and we use them a lot because we do see some of these anomalies that there may only be 15 cases in the United States, and hey, we just so happen to be transporting one because they're here and within our region.
Yeah. We kind of talked about, is there a scope of practice difference when caring for an adult versus a child? So if they're FNP or pediatric NP, then they're a provider essentially, right?
Mm-hmm. Yeah. There was a question that just popped up on the chat that wanted to know about using NPs in our protocol. Yes, so we have a protocol committee, and we have nurse practitioners on our that are helping drive some of those protocols, working with our medical directors and the rest of our colleagues. And so we are helping drive those protocols with the most current literature, not just within the institution, but with healthcare as a general rule. So evidence-based practice.
Yeah, that's a good point. You may have an NP on your team who used to work in neuro ICU or whatever. They can lead the protocol on stroke and stroke management.
Mm-hmm.
It's building a team of specialties, and I've seen that done elsewhere as well. Did we hit everything in that question from Eric? I feel the NPs can really offload the physicians in a lot of stuff, and often they have a lot of experience, like an NP who had worked in the neuro ICU, writing a protocol over, let's say, an ER physician with kind of a broad knowledge.
Mm-hmm.
You can argue who's better, but that, I think what makes sense is to build on whatever the NP's background is to kind of head the education and protocol development in that area.
Yeah, and that's how we're trying to. That's how we've kind of moved forward with some of ours. We also utilize the experts within the institution. So if it comes to neuro, we use not necessarily the chief of the division of neurosurgery or neurology, but we are working with the attendings, and some of our nurse practitioners are helping drive that as well. And we've got our critical care paramedics that are helping do some of these. We've got our critical care nurses that are helping do some of these. But we're really trying to, as we're moving forward with our SOP, we're getting our nurse practitioners highly involved in this.
I'm curious, are your NPs used for medical command for, like, let's say, nurse paramedic crews instead of calling a physician? Because that's another opportunity.
We have looked into that. We use, if the nurse practitioner is on the aircraft, they can act as their own. We are also looking at, because our shift operations center is active 24/7, and we've got a radio in there where we can talk to the aircraft. We're in some discussions with our medical directors about trying to utilize them as a first line before reaching out to our medical control in the emergency department.
So Dave Holloway, he wrote in the chat that the clinic uses that model extensively, and I don't want to speak for Dave, but just in regards to his question, the next session at the end of February with Dave Holloway from Cleveland Clinic CCT, he'll touch on how they use NPs in that kind of oversight model for everybody in the group. I hope you can attend.
Next question: did you work as an RN or paramedic in CCT before becoming a CCTNP? You said yeah.
Yes.
I think we both agree that that experience is huge. Hugely
Yes,
valuable.
it is huge.
Yeah. Do you consider this experience important? Yeah. Yeah, for sure. Can you describe your transport program and how NPs are used? You have already done that. What other responsibilities do NPs have in your program besides clinical duties? Kind of led the way with that.
Can we just do a quick recap? So you guys are in the transfer center.
Yes, so we operate within the transfer center. So we take basically any transfer that's coming to our facility, we'll accept them on behalf of the triage attending. So it offloads that from the triage attending. We also act within the nurse practitioners in the operations center. If a local ER calls and says, hey, I've got this, I'm not sure whether I need to transport it, rather than having to have that discussion with the triage attending, they can say, yeah, here's kind of like our protocol. Here's how we treat this patient. And I don't think that they need to be transferred, and have that dialogue with that attending. And if they feel comfortable at that referring, oh, okay, you know what, you're right. I just wanted to bounce it off somebody. Yeah, we'll keep them. And so they can have some of those discussions. We are also do the event medicine side of the house, where we'll put a practitioner in the treatment tent at those venues, and then we can kind of do the treat and release for those that don't necessarily need to be transported in the emergent. Obviously, if it's an airway issue or cardiac failure or some of those, yeah, they're going to get transported. But if it's hey, I fell and I've got a laceration, we can sew them up. Or hey, we do a lot during the summer, and if you're familiar with the South, and especially being landlocked, it's extremely hot and humid, and so we see a lot of dehydrations. So give them an IV, give them some fluid, make sure that they're back to their baseline, and then we can discharge them from there and follow up with their PCP, that kind of stuff. And then we also have our research, our education, and so we try and utilize them in our referral hospital, or our other regional hospitals that we've bought that belong to Vanderbilt. So we'll utilize them in the emergency department or their ICUs to help augment as well. So we've got a large areas that we can operate in and help out in. So,
can you briefly talk about the rapid response? You mentioned something about rapid response earlier. Can you briefly touch on that?
Yeah, so we have a full-time rapid response team within the institution, and so they don't cover the ICUs, right? Because we've got full-time nurse practitioners that are monitoring the ICU, but they'll get called to rapid responses within the the institution. And so some of our nurse practitioners work additional shifts, picking up in the rapid response team to help augment them, because, it's a 24/7 job. And so they come with a wealth of knowledge, and they've seen, the gamut of type of clinical scenarios that we transport. And so it just is a value add to them.
But the rapid response team is not run by LifeFlight.
No, it is
Okay,
not run by LifeFlight. It's run separately, but those are ways that we're helping to augment the institution.
It's another
Excellent.
perfect role for the flight NP, though. You guys can
Yeah,
take
it's
over, go to the
Yep.
codes, and
and it'd
there's
be great
not a lot of
procedural
that.
experience too, keep up the procedural skills.
And who knows how to work outside the box, right? And
Yep.
see all these things. So it's a perfect opportunity. Do CCTNPs make more money than CCTRNs? I will say the programs I'm familiar with, they do. I'm not sure if that's the same for you.
Yes,
And
we try not to talk a lot about money.
Yeah. don't
But
have
yeah.
I think that's one of the things I, as an NP, and everybody, you go to school longer, you want to make more money, right? So
Yeah.
again, you got to bring the value.
Yeah.
If you bring value, you'll get compensated for it. And that's the goal here. Bring the value and then get compensated for your value.
Yep. And we've given them, they get a $2,000 a year stipend for continuing medical education, which is in line kind of like with the rest of the APPs within the institution. So
and again, you don't have to answer details here, but the goal for me and my vision is to have CCTNPs compensated like they are in the intensive care unit or the emergency department. Is it similar for your program? Is an NP that works for you compensated what they would be if they work in the emergency department or ICU, or comparable?
So we had been doing a lot of work around that and trying to get them compensated based on job description and job code. And so we've put a lot of work around that. So we are in the process of getting all that changed currently. So like within the next few weeks.
How do CCT programs who use NPs offset the additional costs associated with employing NPs? We kind of talked about some of this. I think it's to add the value, and you're welcome to expand on it. This paper that's coming out will highlight a lot of this.
Well, I think that some of the ways that we've been able to do that, and I didn't mean to interrupt, but some of the ways it's even utilizing our shift operations center where we have the nurse practitioners that are accepting on behalf of the emergency department triage physician. It increases their throughput and increases their ability to be able to focus on what's in front of them without being distracted on the other part. And then creating that huge dissatisfier with the referring physician who may be sitting on hold for the next 15 minutes because the triage attending is involved in something else. It helps expedite the process. So granted, those things are not always a direct correlation with cost savings, but it can be with job satisfaction and throughput and efficiency.
I do want to be cognizant of your time, Keith. I think, are there differences in scope of practice between CCT, NPs, and RN? We kind of talked about this. Basically, they're autonomous. They can practice at their level. They can deviate from a protocol.
Yep. Yeah. And we always tell them, like, if you're not comfortable, fall back to your protocol, because your protocol was written by the expert in that field. So your stroke was written by the neurologist. So, but if you feel like, hey, this is something I need to expand beyond that, as long as you, like everything else, document why you're doing it, you're within your scope. Stay within your scope, and you act as your own medical control.
Yeah, I mean, I feel most protocols are pretty good, but there just are certain times where you know, in your head that maybe I should deviate from this a little bit, or it's outdated, maybe, you know.
Yeah.
So what
Yeah,
are
and there are
obstacles?
certain instances, I'm sorry, I have one more thing. There are certain instances where you have to call back to get approval to get this medication. Well, I'm my own medical control. I'm not going to spend, the next 4 minutes on the radio trying to communicate when I know that's the right thing to do as a practitioner. So,
Right, airway might be one. I know some programs you're required to make a call to intubate somebody. Not that we're gonna go cavalier and intubate people,
right.
but we can make a call when somebody. I think most flight nurses, paramedics understand when somebody needs intubated and maybe the call isn't needed. I feel that being a provider, you can just do it, you know.
Yeah.
Part of that though is living with the ramifications of your call, you know, so it kind of forces you to stay on top of your game because this is your license here, you know.
Yep.
What are obstacles that hinder or limit the potential of NPs? This could include factors within your program, CCT as a whole, or even government operations.
I'm going to say probably probably the biggest hindrance is pay. I mean, finances. I hate, as much as healthcare. We're here to take care of patients and do what's right for them. It's still a business, and we still have to operate in the black if we want to be successful. So I think that is an obstacle. I think in different regions, the obstacle may be physicians are not acutely aware of what a nurse practitioner's scope of practice is and what they can do. We are lucky at Vanderbilt in that nurse practitioners are everywhere within the institution. We have a school of nursing that promotes that, as well as they see the value add, especially as they all rotate through the different departments and see the value that the nurse practitioners can bring. I'll use a research study for the trauma nurse practitioners. They were able to reduce the length of just the nurse practitioners alone were able to reduce the length of stay by 1.3 days in their latest research study. That's huge when you think about the turnover rate of patients coming in and out of the trauma unit when they're seeing 10, 12,000, 14,000 trauma patients a year. If they can reduce that length of stay, that actually helps the hospital itself with the capacity issue. So I think that being able to educate on what the value add and what your plan is and how you want to incorporate them, but what else they are going to bring to the table. I think that is the way to overcome some of those obstacles, especially from a knowledge deficit.
How do you keep up to date with the latest advancements and protocols in CCT? What strategies do you use to maintain your composure and effectiveness in high stress, fast paced environments like CCT?
So up to date, I alluded to an academic institution. We always are looking for what is not necessarily the latest and greatest, but what is the best evidence-based practice. So working with our physician colleagues, and then we have a research arm, again, of our nurse practitioners that are constantly digging into what is the latest research. And just because this is the latest research, has this been proven? Is this a peer-reviewed research study? So they take a lot of those things into play, and then we'll look at it and go from there. Is this something that we need to change our protocol? And I've got all this great research that's showing this is our new evidence-based practice. Let's bring it with our medical director and let's talk about, hey, how we need to change our protocol. So I think that's how we stay up to date on a lot of those. And then strategies is how do you maintain your composure and effectiveness in high stress? I hate to use that, but a lot of us are type A personalities, right? So, and it's not a control thing. It's just we are type A. We want to see the best outcome of the patient. I have seen where some highly intelligent individuals do not work well in high stress situations, and have created some negative. I'm trying to think of the best word. They've created some negative things that we've had to overcome. So I I use this a lot, and I use it with new orientees: slow is smooth, smooth is fast, right? So if I'm rushing into something and I'm really, can't maintain my composure and I'm really highly stressed, what are the odds of me being successful in this airway? Probably not very good. So I tell everyone that I work with, like, this is the patient's emergency, not necessarily mine. It's my job to take care of that patient and make sure that they have the best outcome. So take a breath. And remember, everybody is looking to you and relying on you to be that rock in there. So you can kind of be like a duck, you're smooth on water, but your feet are going just like this. That, and also decompressions, right? So after some of these high stress environments, take time to decompress, talk to your colleagues. We have a great flight chaplain that is part of our program. We also have a, why is this eluding me? A peer support program. So anytime that we've had some bad flights or somebody finds out, hey, they took care of this neonate and they did not have a positive outcome, we put that information to our peer support, and they reach out and say, hey, understand you had a very bad flight. Is there anything we can do to help you? And so we have a great, strong peer support team. So that helps a lot too.
Finally, unless there's chat questions, is there anything else you think we should know about NPs and CCT?
I'm going to say, I think we've covered a lot. This is the first in a series. I think we covered a lot of the information of, we're not the end all be all, but this is how we're doing it. This is how we've been successful at it. I think NPs are a great value add to critical care transport, but I think it takes a team, and the team is all of those involved. So that meaning from our maintainers, our pilots, our critical care crews of paramedics and nurses, NPs, physicians. It takes, I hate to use this, but it takes a village, right? So I think it's going to take everybody, but the way that we want to see NPs be successful is to operate and use them to the fullest scope of practice. And some of that is educating your colleagues. Some of that is doing the research. Some of that is being your own medical control, but being up to date on the information. Because I think everybody can attest, you've flown into that ER where, the ER provider may not be the most up to date on the latest information, and they're using stuff from, the 90s. And we've evolved since some of those. And I think that that's the thing that we have to do, is how do we evolve? And we have to stay at the top of our game. So.
Keith, this went by so fast. I can't believe it's almost 2 hours. You guys, anybody can reach out. You can email me. My email's in the chat. Unless there's any other questions for Keith. Do you see any in there? We're going to have 3 more of these. Keith, you're welcome. Everybody should have the invite. If not, they're on Facebook. And then we'll get the perspectives from the Cleveland Clinic, from Metro LifeFlight, and then from Jacob Miller. And hopefully more programs will try this model, and we'll help them succeed.
I hope so. I mean, it's, for us, it's been a success. Granted, everything has its little hiccups, but I think that we have shown a value add to not just the program, but our patients and the institution as a whole. So I hope other programs see and can maintain or see that it does bring a value add, and they approach this.
Yeah, sounds good. Hey, I'm going to have to go on vacation to Tennessee and take my family down there, and then I'll look you up and we'll get lunch or something. All right.
All right.
Yeah. Any other questions? I think that's it. Thanks, Keith. I appreciate it. I'll be in touch.
All right.
Thank you so much. Everybody like our Facebook and reach out if you have any questions or concerns so we can grow the community together.
Yep, absolutely. And my email, I think, David, you can put it in wherever you need to. People are welcome to email me if they have any questions or any concerns. Feel free.
Yeah, if you just Google Vanderbilt LifeFlight, I think that's how I got a hold of
Yeah.
you. It's right there, and yeah, or they can email me and I'll send it to them.
Yep.
If you come through the flight center, then we'll kind of know what's going on and we can keep track of things. And so thank you, everybody.
All right.
All right, take care.
Thank
All
you,
right.
guys.